Good afternoon. My name is Paul Wax. I'm the Executive Director of the American College of Medical Toxicology, and I'd like to welcome you to our webinar series, Medical and Public Health Considerations of COVID-19. This is part of our special collaboration with the Pediatric Environmental Health Specialty Unit group and the American Academy of Pediatrics, as we're offering this mini-series on safer disinfectant use in COVID-19. Today's presentation is titled Disinfectants, Sanitizers, and Reproductive Health. Next slide. Here's this disclaimer. Funding for this program was supported by the AAP and funded in part through a cooperative agreement with CDC and the EPA. Next slide. I'd like to thank our webinar series partners for helping to promote our webinar series. Much appreciated. Thank you. Next slide. This is the fourth in a series of 6 webinars about safer disinfectant use. This will be recorded, and like the others, will be put up on our website, which you can see below. We will also be developing a FAQ as part of this presentation. Next slide. And this is the website of the FAQ. And again, within a few weeks after this presentation, we'll have a FAQ up about this particular webinar. Next slide. There will be a Q&A at the end of the webinar. This is an important component of the presentation. We welcome your questions. Please type them in to the Q&A function, and we'll try to get to as many of the questions as possible. Next slide. I'd like to thank my co-moderator for this series, Dr. Ziad Kazi, who's the Secretary Treasurer of ACMT and past president of the Middle Eastern and North African Clinical Toxicology Association, Associate Professor in Emergency Medicine at Emory. Ziad and I have been doing this now for the last 16 months, and I really appreciate his ongoing support. Next slide. It's my pleasure to introduce our guest moderator today, Dr. Claire Coles, is a professor in the Department of Psychiatry and Behavioral Sciences at Emory University. She's also the director of the Center for Maternal Substance Abuse and Child Development at Emory University, and she'll be helping out with the moderation of the Q&A at the end of the talk. Thank you, Claire. Next slide. Our speakers do not have any conflicts of interest to disclose. Next slide. So we have 2 speakers today. The leadoff speaker is Dr. Rose Goldman. She's an associate professor of medicine at the Harvard Medical School and associate professor of environmental health sciences at the Harvard Jan School of Public Health and director of faculty affairs at the Department of Medicine at Cambridge. And she'll be leading off our presentation today, and we very much look forward to her presentation. Next slide. Our second speaker is Dr. Alfred Romeo. He's the president-elect of the Organization of Teratology Information Specialists and is a teratogen information specialist. And he works at the Utah Department of Health in Salt Lake City, Utah. And thank you to Dr. Romeo as well. And on this note, I'm going to turn it over to Dr. Goldman for her initial presentation. Thank you.
Thank you very much, Dr. Wax. It's a pleasure to be able to talk to people about this issue that really came up as we were in the midst of the COVID pandemic. And there was a great effort to reduce transmission, as we know. And so with utilizing a lot of hand sanitizers, disinfectants, particularly in the early days when there was a great concern about surfaces. And so questions were coming to us at the Pediatric Environmental Health Units, and I'm sure to ACMT, about whether or not this had any impact on people who might be pregnant. And this raised a lot of questions concerning that and led me to really look into what are these sanitizers and disinfectants, and what do we know and what do we don't know about their effects on the reproductive system. Mostly, I'm going to be talking about the female systems. Could we have the next slide, please? So my learning objectives here are to describe and know the differences between what we mean by a sanitizer and a disinfectant, and to know, be able to describe what we know about potential exposures and adverse reproductive outcomes, particularly focusing on the 2 most common hand sanitizers, alcohols and benzalkonium chloride. Next, please. So let's start by saying, well, what do we really mean by an antiseptic and a disinfectant? So an antiseptic is usually defined as a chemical that's applied to living tissue to kill or inhibit microorganisms. And when we say a hand sanitizer, we're really talking about something that's an antiseptic. And as we know, some of the antiseptics that we've used on the hands have included wipes, squeeze bottles, gels, foams, and even small hand sprays. In contrast, what is a disinfectant? And here we're talking about a chemical that's applied to an inanimate object, like the surfaces, to kill or inhibit microorganisms. And again, here we could have wipes, sprays, liquids. Next slide, please. So if we look at the list of these things under antiseptics or hand sanitizers, as we've all heard, using soap and water to clean our hands, not even an antiseptic soap, is very, very useful for getting off, besides soil and dirt, but also a lot of microorganisms. And that's certainly our first order. But we can't always have readily available soap and water. And so what we've gone to are hand sanitizers. And in this realm, we know that we have alcohol, such as ethanol or isopropanol alcohol. And we talk about, quote, rubbing alcohol, which is 70% alcohol. And when we talk about effective hand sanitizers, we're talking about something that has anywhere from 60 to 95% ethyl or isopropyl alcohol. Another hand sanitizer that you might have seen on many of the packages that you've been using is something called Benzalkonium Chloride. And it's usually in a percentage that's something along the order of 0.13%. And the actual long chemical name for this agent is alkyl dimethyl benzyl ammonium chloride. And this agent is part of a larger group of thousands of chemicals called Quaternary ammonium compounds. In addition, if we talk about antiseptics in the larger scheme of medicine, there are other agents that you might have heard of for skin sterilization in the healthcare setting, such as iodine, chlorhexidine, hydrogen peroxide in a weak concentration. And we won't be talking about those agents, which are typically applied for a short period of time to sterilize the skin. On the disinfectant side, we have hydrogen peroxide, usually in higher concentrations, but particularly during this time, the use of quaternary ammonium compounds. And here, if you look in the healthcare setting, you will see these as wipes. You'll also find them in multi-use kitchen cleaners if you look at the labels. And in this group, two of the most common ones in these thousands of chemicals are, again, the dialkyl dimethyl benzyl ammonium chloride, which I just mentioned before, as well as another similar group, the N-alkyl dimethyl ethyl benzyl ammonium chloride. So this is a big mouthful to say for chemical names, but just to let you know that when you look at a label and you see those kind of chemical names, this is the group of chemicals that we're talking about, the quaternary ammonium compounds. Next slide, please. So what are these quaternary ammonium compounds? These are very active surface agents. They all have this chemical sort of formula that has an ammonia. That's what the N is. And various groups that have carbon and hydrogens that are called alkyl groups. They're all in a way derivatives of ammonium chloride. There are many compounds, as I mentioned, and the two most common used for disinfectants are benzalkonium chloride and the alkyl dimethyl benzyl ammonium chloride. Next, please. So this is just something that I had in my own kitchen, just to show you here that the active ingredient here, you can see that name, alkyl dimethyl benzyl ammonium chloride. And here you can see that it's actually in a higher percentage than I mentioned in the hand sanitizer, 0.26%. And of course, there's always inert ingredients in these cleansers. And so this is listed on the spray can as a cleaner and a disinfectant. Next, please. So what do we know further about these quaternary ammonium compounds and how they're regulated? And interestingly enough, because they're antimicrobial and they kill microorganisms, they're sort of in a category of antimicrobial pesticides. And in the US, they are regulated by agencies such as EPA and FIFRA. And to be registered, EPA requires data about the antimicrobial efficacy and also the absence of adverse effects, both on the human and the environment. These chemicals are also subject to regulation by the Federal Food, Drug, and Cosmetic Act, and FDA ends up regulating antimicrobial agents when they actually enter and become used as a drug or an active ingredient. So you can see that there's a lot of agencies sort of involved with these compounds. Next. So these compounds, again, not to get too much into the weeds of the chemistry, there's two different types of them, the DDACs and these alkyl ones. And basically, a lot of the research involves both of these different kinds of compounds, but the majority of the toxicology data that's publicly available as part of this registration process, and not necessarily in peer-reviewed journals. And so it's the companies that are frequently submitting studies, and they may be many of these unpublished reports that then EPA will use in terms of certifying it. And there was an article, a nice review article of the human health hazards associated with these quaternary ammonium compounds based upon review of these submitted studies that was published in this journal in 2020. Next. Now, looking at the studies, first of all, most of them are animal studies. And the other very important thing to know, which I think is useful to us also as humans, is that these chemicals are not readily absorbed by the skin or the gastrointestinal tract, and not more than 10%. So most of the studies, if you look at them that were done in rats and rabbits, the developmental studies, the doses were administered via gavage, which means through the throat. And you did see in these high doses that were administered that way, some adverse effects such as reduced fetal body weight and an increase in the number of dead fetuses. But apparently that was only at levels that were very toxic to the mother rodent. In addition, prenatal administration, they did not report in these animal studies developmental toxicity at doses that were not maternally toxic. Next slide, please. Going on about these animal studies, they also looked at effects on reproduction in multiple two-generation reproductive toxicity studies in rats. And in mice that were fed large quantities of these QACs, they did see effects on fertility, ovulatory capacity, and sperm abnormalities. So as you can see, yes, there might be something going on from animal studies, but it leaves us questioning how much would this apply to humans. And an important point here is particularly if the level of absorption to the human is fairly limited. And then that raises what can we do to limit absorption. Next slide, please. In the realm of human studies and reports, if you look at these quaternary ammonium compounds, most of what we see are reports related to their irritating effect to both skin and mucous membranes, with some of the studies noting that these could be allergic reactions, which has been somewhat controversial, but everyone agrees that these are very irritating. And so that if you do get exposure to these, one could get certainly an irritated nose and throat, and if one had asthma, perhaps precipitate an asthmatic attack, which is not something we would want to see in any of the workers, and certainly not somebody who would be pregnant. Next slide, please. So I'm going to turn next to another common hand sanitizer, which are the alcohols. And here we have ethanol and isopropyl alcohol, rubbing alcohol, and hand sanitizers. And we know here, in terms of alcohols, we know that ingesting alcohol, ethanol, is dangerous to the developing fetus. There's the alcohol syndrome, and also just general adverse effects to the developing fetus. And so, as usual, women who are pregnant or planning pregnancy are usually advised not to drink ethanol. So now the question again becomes, in the use of alcohol on one's skin, do you really absorb enough that this could be an issue in terms of getting a blood level, because the alcohol does go across the placenta. Next slide. So that really here is the key, one of the key questions. Do you have systemic absorption from repeated skin applications? Because here's a situation where people are repeatedly putting alcohol on their skin for the purpose of sterilization. And again, this is a situation where we don't have a lot of information. There was a very small experiment with a few people looking at could you measure the amount of alcohol in the blood after applying the alcohol to the skin. And what was found is that when you apply it to the skin in this little study that they did, which is one or two people doing the study, that if you applied it to the skin and put your hands right by your face, and you did that for a minute or so and went to another room, you could then within a few minutes measure some alcohol in the blood. But if you applied it to the skin more at waist level, you didn't really get much of an exposure. And a part of this little study was raising the fact that perhaps the issue here when you apply it to the skin is much more one of perhaps inhalation. And this certainly, another interesting study came up because nurses who were using a lot of alcohol sanitizers, I don't want to say the usual name, when they were at work using it multiple times a day, a question was raised: if you got stopped, would there be enough when you were driving, enough of an exposure that you could be thought to be drinking? And at least from studies like this, it didn't appear to be, particularly if you put the sanitizer on not right in front of your face, that there would be much absorption. But it certainly raises the question whether we should be doing more with washing our hands or changing which disinfectant we're using. So that raises the question, is there sufficient exposure to affect potential fetal development? I'm not sure we have a 100% answer for that. Next slide. One of the areas where there is concern, in addition, is that some of these products that people are using may have a small amount of a contaminant that are very dangerous agents, methanol, which is very toxic alcohol, and benzene. And when you actually look at the amount that's in the hand sanitizer, most of the problem is really going to occur in the setting of drinking it or accidental ingestion. And we did a small back of the envelope calculation to see, even in that situation, how much could one ingest and how dangerous would that be. Benzene is also a carcinogen, so one would not be wanting to have exposure to that as well. Again, the question, would a significant amount be absorbed if you were just putting it on your skin? Next slide. From some of the study, just calculations we did, a small group of us, it didn't seem that you would get much absorption through the skin, even of those toxic agents. But it is best to avoid using any sanitizer or disinfectant if it contains any of those toxic agents. So what can we conclude, and how does this lead us to some recommendations? Well, one thing is we just have limited information about the amount of skin and respiratory exposure based upon the usual use of these quaternary ammonium compounds and alcohols. The quaternary ammonium compounds tend to be much less volatile than the alcohols and are not flammable, which makes them a good choice in some ways. And what is available that we know suggests that low to no exposure via skin and inhalation is somewhat encouraging. There is limited to no human studies about reproductive toxicity, and most concern exposures in animals at very high doses, mostly through ingestion. And most of what we need to be worrying about in these situations with humans so far appears to be more one of irritant exposures and skin rashes. Next. So what is a reasonable approach for if we need to use a hand sanitizer? One is to start by using soap and water whenever possible, and it is a reasonably effective, particularly if you do it in the proper method over 20 seconds. If it's not available, you could use a hand sanitizer, an alcohol-based hand rub with at least 60 to 95%, and that's one that's generally preferred in the healthcare setting. It's really important to check that the product has no contaminants, and you can go to an FDA website to be sure that whatever product you choose is not on that list. One can consider alternatives if they're effective and safe, and you can go to the EPA websites to see what else could be considered safe and effective. And the other important point is not to use the agents for the surface disinfectants for hand use. Next. There is a list of products that are effective against COVID-19, which you can find at this website. A good approach to the surfaces is to clean the surface first, use gloves and recommended protective measures when disinfecting. Limit the amount of just spraying something over things. You can reduce the aerosol amount by using wipes or putting the spray on a rag rather than just spraying over a surface. And then the EPA has a nice little chart for steps for safe and effective disinfectant use, and importantly, to store all hand sanitizers and disinfectants out of reach of children, because children may find them appealing and colorful and something that they might be ready to ingest or to play with the sprays. Next slide. And this is if you were doing some education with other colleagues or with the community. This is a nice handout that was prepared by EPA that sort of goes over these key things for using a disinfectant. Next slide. So these are some references that people may find useful. And I'll stop here and turn it over to Al Romero.
Thank you. Yeah, so we're going to talk a little bit more in detail about pregnancy and lactation. So on the next slide, just a thank you to the different organizations that made this possible through their collaboration. Thank you to, of course, Otis, my home organization, the American College of Medical Toxicology, Pediatric Environmental Specialty Units, for all of the collaboration that made this possible. Okay, so a couple of those learning objectives. We're going to talk about some principles of teratology. We're going to identify the background risk for major birth defects in the U.S., and we're going to talk about risk statements for human studies. So a little bit about those Tradogen information centers where all of you can learn more about and ask questions about some of these different exposures in pregnancy breastfeeding. So the Organization of Teratology Information Specialists has MotherToBaby affiliates at 14 different centers across North America. I'm at MotherToBaby, Utah, and we cover Utah. We do, for those 14 centers, cover regionally all of the United States and territories. So anywhere in the United States, you can reach us. We do answer questions about any exposures in pregnancy and breastfeeding. And we take those different questions by phone, text, chat, and email. Remember that there's sometimes questions about HIPAA compliance. Remember that these questions that we're responding to, they're incoming questions. So we don't have access to any of their medical information. They're calling us or texting us or chatting with us and giving us the information that they want to share with us. But of course, those different systems have HIPAA compliance and different protections in them. For example, our phone system here in Utah, we use the same phone system that Medicaid uses. So it's not our desk phone, it's not our personal phone. We log into a Genesis system and the incoming calls come to that system and we log into that. So there are protections there. For text and chat, you see Mozio there. That's the texting system that we use. It was designed for healthcare. For chat, we used Live Help Now. Again, we log into these systems so that we respond to those incoming questions to the system, not to our individual smartphone for text or chat or those types of things. Email, again, we log into the system. You see an image there on our national website, MotherToBaby.org, where you can email an expert and it'll route it to whatever service is covering for that particular zip code that or area code that you're going to call into. So yeah, the telephones, that 866 number, it will route to the different area codes. And like it says, for the email, it'll route for the different zip codes. On the next slide, here we go. So we're going to talk a little bit about the Shepherd's criteria for proof of teratogenicity. This is important to remember as we're looking at those different exposures, reading through the research articles about those different exposures to see if they cause birth defects. For the different exposures, one of the things to remember is that we have these different criteria to make sure that we're reaching that level of heightened so that we prove that there's exposure. So this article by Rasmussen et al. In 2016 was about Zika virus. So as you remember, for the Zika pandemic, we were watching those different reports come out from some of those different countries, and we were seeing some different things that cause concern. And we were waiting for the CDC to make the definitive call for whether or not that caused a birth defect. So this is that article that made that definitive proof. And we're going to look at Shepherd's criteria. Bradford Hill criteria is included in the article also. But one of the things is that proven exposure to the agent at one or more critical times during prenatal development. So we do know that, yes, Zika, mom had the Zika virus and it was transmitted to the baby. So we had those research findings that it was transmitted to baby. The second item there is the consistent findings by more than 2 high quality epidemiologic studies with control of those confounding factors, sufficient numbers, exclusion of positive and negative bias factors, and the prospective studies if possible. You'll see there that we look for a relative risk greater than 6. Now, a lot of the different research studies that we're reviewing, we'll see those odds ratios or relative risk ratios in the 1 or 2 areas. We watch those, but don't get too excited about those. For example, Zika virus has an odds ratio of 50. So we do expect those that are definitely teratogenic to have those higher odds ratios. Another one of those criteria is careful delineation of the clinical cases. Do we know that, of course, they had that exposure? Then we're looking for a specified defect or syndrome. Do we know that they had that particular effects from it? And with Zika virus, what we were seeing is the brain and the skull start to develop, and then it appears to be some type of effect on the fetus, and there's a shrinking. So you get those specific folds of the skin over the scalp. So a very specific defect, a very specific thing happening Again, the next one is a rare environmental exposure with a rare defect. So yes, we're seeing Zika virus, something very rare happening, and we're seeing a very rare type of microcephaly that we don't see anywhere else. We're also looking for teratogenicity in experimental animals. It's important but not essential. As we already heard, some of those animal studies, they're set up a little bit different, usually higher exposures and those types of things. So we don't always rely upon those, but those are helpful for red flags and looking for whether or not there's that, as the next one says, biologic sense. Do we see that same kind of pathway happening? And then for more of the chemicals and medications, proof in an experimental system that the agent acted in an unaltered state, usually talking about metabolism, those types of things. So at the bottom, you see image of the Bradford Hill criteria. Again, the strength of association is one of those criteria. And again, the approximate odds ratio of 50 for Zika. So what is a teratogen? It's any external exposure which causes structural and or functional defects. We talk about these as teratogens, so they're excluding all of those genetic conditions. So you'll see over in the right in the image, that circle is from a Utah study, and it includes all of those different babies with birth defects. So that red area are those with unknown etiology. And yes, most of those birth defects, we don't know how those happen, but there are a significant amount of those in that purple area off to the right, and those are from chromosomal abnormality. Then the blue on the right, a little bit lower, you'll see those with the genetic abnormality. So again, these are not the teratogens. That little green sliver down there, kind of teal sliver, it's labeled 46. Less than 1% of this study are caused by teratogens. So that's the exposures that our expertise is in. And then you'll see all the way at the bottom that more dark green for twinning. So a little bit about the background risk. We do expect there to be a 3% to 5% chance of a major birth defect for any healthy pregnancy. So that's where everybody starts. And then we talk about whether or not there's an increased risk or not. Remember, there's always that 15 to 20% risk for miscarriage and a 5 to 25% risk for developmental delay. And when we talk about exposures, oftentimes we're talking about medications and we talk about benefit and risk. Is the benefit of using that exposure medication worth it for whatever risk? Remember that the untreated condition has risk also. Diabetes is a good example. Untreated diabetes increases the risk for birth defects, spina bifida, heart defects, those types of things. So not taking a medication can increase the risk also. So again, that risk benefit. Remember to not use those old Fda pregnancy categories. The FDA stopped using those in 2014. There was misunderstanding about how to use those different categories. So the FDA is never going to update those again. You may still find them in the reference books. We still have clients and providers calling on a regular basis saying, you know, we see this category, what does that mean? Again, we don't use those categories. They will never get updated again, so please don't use those categories. The FDA moved to a more narrative type of system. Okay, and then for research, as we have seen, some of those different disinfectants and sterilants don't have enough research, and there's a need for more research. One of those ways that we do that is the registries. So there's registries for antipsychotics and antiepileptics and a variety of different medications in pregnancy. And those help us learn more about some of those different red flags and point us in the right direction for some of the other research studies. Now, Otis MotherToBaby does have an arm that does those research studies out of MotherToBaby, California, and they're looking at medications, vaccines, and a variety of different conditions. COVID-19, the vaccines and the condition are included in those research studies, and we're trying to learn more as we go along. The PregLac, if you've never heard of that one, that's the task force on research specific to pregnant women and lactating women out of the National Institutes of Health, NICHD, and there's a companion project They are a little bit ahead of us. In Europe, it's called conception. And what this project is, the task force has already released its recommendations, but in the US, there isn't funding behind those yet. In the conception project in Europe, there are millions of euros behind that project, and they're going ahead with research projects. But here in the US, there's just those recommendations. One of the reasons that we see the PREGLAC recommendations as so important, you can see out of the COVID-19 vaccines issue. We are trying to protect women with research, not from research. With COVID-19, there were pregnant women enrolled. Well, there were women enrolled in those COVID-19 vaccine studies, and they became pregnant. And once they became pregnant, they were excluded. So one of the things that PREGLAC hopes to do is change the culture from automatically excluding pregnant and breastfeeding women from those research studies to turning around and automatically including them unless there's a good reason to exclude them. So yes, for COVID-19, the disease, there's greater risk for complications in pregnancy, difficulty breathing, ECMO, and of course, death. The disease is worse than those vaccines or treatments for COVID-19. And because of the lack of having pregnant and breastfeeding women enrolled in those early research studies, there's a lot of misinformation, conflicting messages, and fear. And some countries don't even allow their pregnant and breastfeeding women to get those vaccines. So that's caused a great deal of complications for helping women to understand about the vaccine. Since November, that's been our most common question, is about the vaccines, COVID-19 vaccines in pregnancy and breastfeeding. So let's talk about a little bit why we're here today, the disinfectants. So you have a picture of one of those orange ones that I have in my household, and you'll see that it has lactic acid in it. So we're going to talk a little bit about some of those disinfectants for cleaning surfaces at home and occupational settings. We're going to talk just a mention about those antiseptics and hand sanitizers. So for those different disinfectants that have been approved for use for COVID-19, they've been approved by the EPA. You see the website there was mentioned in the last, Dr. Rose mentioned it, Dr. Rose Goldman mentioned it in the last talk. So all of these are listed there on the EPA's website. You'll see some of those common ones, citric acid, alcohol. Of course, we're not talking about drinking it, but we're talking about, the hand sanitizers, glycolic acid. Some of the other ones, hydrogen peroxide, lactic acid, sodium hypochlorite or bleach. So there's a variety of those different ones, the quaternary ammonias that we heard about, a variety of those ones that we see in that list. So some general principles for pregnancy and lactation: of course, don't ingest those cleaning products. In the absence of, as we heard, in the absence of toxicity, of a exposure where they're ingesting it, we don't see an increased risk of birth defects or other problems in pregnancy or breastfeeding. Of course, use good ventilation. You may smell the product, but not likely to get very much of a dose through that inhalation process. Of course, use all of the different protective equipment that's suggested or required for that particular product, whether it's gloves or mask or goggles or other protective equipment. And then if you do start to have too much symptoms, headache, nausea, vomiting, dizziness, those types of things from smelling the product, of course, take a break and get some fresh air and then come back to it. Of course, use as directed on the package, and of course, don't mix it. We all know about mixing bleach and ammonia produces toxic gas. So don't mix those different cleaning products, use them separately. And for pregnancy and breastfeeding, and for all of us, of course, wash hands before eating, breastfeeding. Those animal studies, as we have already heard, may not be as useful because they are different in the route and the dose of the different types of exposures that we're seeing in those studies. So a few of those different exposures for pregnancy and lactation in particular: citric acid, there's no increased risk for using it as a cleaning product. Of course, alcohol, we've already mentioned, no increased risk for using it as a cleaning product. Of course, we're not talking about ingesting it. Glutaraldehyde, no information on that one. The glycolic acid, it's a metabolite of ethylene glycol, not likely to see any increased risk used at typical levels for cleaning. Hydrogen peroxide, no increased risk for use in cleaning. Lactic acid, again, no increased risk. The peracetic acid, no information. Phenolic, remember that one has salicylic acid in it. Of course, avoid aspirin in pregnancy, particularly later in pregnancy, because it can cause complications. But again, that's not the way that it's going to be used as a cleaning product. The quaternary ammonias, again, lack of information on that one. And bleach, no increased use for cleaning the way that it's going to be used typically. For those wood alcohol sanitizers, remember they're not approved. Remember that the clients that you're going to be talking to, that we talk to on a regular basis, are concerned about some of these different exposures. And I once had a woman call. She used a wood alcohol sanitizer, and the news reports had just come out about not using those because they weren't approved. She was considering having an abortion because she used that alcohol hand sanitizer one time. So there's a lot of misunderstanding about these different types of exposures and how much exposure a pregnant or breastfeeding woman can have or should have. So a lot of information about there that we have to dispel the misinformation that's available. Also for COVID-19 transmission, remember that our surface cleaning efforts, of course, may have been beyond what is needed, but I'm still cautious with some of those different things that come into my home. So just a couple of notes about some other disinfectants and sterilants. Ethylene oxide isn't used very much, but just to kind of show how some of the different research studies are used and those principles of teratology. There were 4 studies on that one with mixed and weak information on miscarriage. There were a low number of participants. The exposure wasn't clear. We're not seeing any patterns or outcomes for those. So not likely to cause a problem in pregnancy. Formaldehyde, again, mixed and weak information on miscarriage. Remember that it can cause respiratory complications before there's significant amounts in the bloodstream. For the OPAs, no information on those. And then another note to remember that some of those different occupational studies have shown increased risk of miscarriage from the work environment. When we look at some of those different work exposures, occupational exposures, it's not necessarily the exposure that's causing the issue rather than the occupational environment. If you're on your feet all day long, standing, not getting breaks for 8 hours or 40 hours or 60-hour work weeks, it causes stress, and that stress can increase the risk for some other different problems, miscarriage and those types of things. So just kind of be aware of that. The references are listed here for some of the different things that I've mentioned today, and we're happy to answer any of those different questions that you have for us today.
That was lovely. Really found it very informative. Shall we go ahead with the question and answer, Paul?
Yes.
All right. They're coming in on 2 sources. Chad has a few, but I'm going to start at the top. You mentioned that the studies used for EPA, FIFRA, are not peer-reviewed. Are you discounting that they utilize protocols reviewed and endorsed by global risk management agencies? Additionally, these study reports are audited under GLP protocols and analyzed by toxicologists. These protocols have been developed for risk management programs.
Yeah, no, that's a good point. I meant by peer review, these are not these were not published in the usual medical journals, but certainly there are the protocols, and those were developed totally, and those are what are used for the risk management decision making. But it isn't, you know, where it's published in a medical journal where other people could be looking at it and easily find it. Do you want me to go to the next one? How are there serious concerns about antimicrobial resistance from quats into these takes? That's a very good question. I am not aware of a particular antimicrobial resistance developed to the quaternary ammonium compounds. I don't know if the other toxicologists are aware, or Dr. Romeo.
I don't have any information on this, but I noted the other question regarding not using quaternary ammonium compounds at daycare settings. There was a follow-up question in the list there, list of questions. I've noticed some people coming into the emergency department with exacerbation of their existing asthma or recurrence of their asthma exacerbation episodes after the use of some of these disinfectants that work not necessarily only at childcare setting, but also in other settings such as cleaning services of hotels or cafeterias.
No, I've seen a number of people who have gotten respiratory irritation and asthma exacerbation from using these agents. So I don't think it's an issue of resistance there. And that is one of the major issues with those quaternary ammonium compounds, particularly since they can be applied to the skin. And but I don't know if you develop resistance. Now, one of the things that's important in the hospital setting is that there are certain microbes, this isn't COVID, but like C. difficile, which doesn't really respond well to alcohols or these, and you have as well, particularly alcohol. So you have to do much more hand washing. And I think somebody else I was looking at, somebody raised something about why not use hydrogen peroxide more. And I thought that's a very good question, why I didn't talk about that more. A lot of my talk was focused on the hand, what we're putting on our hands, and hydrogen peroxide is very irritating to the hands. So one would not want to put that on it. The other thing about hydrogen peroxide, it is used to sterilize instruments where you soak the instruments for a certain period of time. In terms of surfaces, there may be more issues about which surfaces you can put hydrogen peroxide on. It has a bit of a bleaching effect. And also my understanding is if you're going to clean the surface or sterilize the surface with the hydrogen peroxide, it has to sit on it for about 10 minutes or something. Whereas alcohol, you wipe the alcohol on and it's about 30 seconds. So that's why people have drifted to using alcohols and quaternary ammonium compounds for the hand sanitizers rather than the hydrogen peroxide.
Another person asks, discuss the safety of diaper changing disinfectants in infants if use is enthusiastic by a well-meaning mother. So, these baby wipe things, I guess. Anybody have any comments?
Go ahead,
For
Dr.
the
Goldman.
baby wipe, for the baby wipe, we're not really going into sterilizing for COVID, I would think. So I think it's an issue of cleaning and wiping, and I don't know that we need agents that are so strong as to for that level of sterilization. You're just trying to wipe away the usual bacterium, but so I think they have a lot of wipes that are more in the cleaning area. I don't know if other people have some other view on that.
Yeah, it's a different kind of thing. And one of the other comments is sort of going on with this is, can you comment on contact times for these? What's the contact time that's required in order to have its effect?
Yeah, that's a very good question. I mean, maybe Paul or Zayed can answer. My understanding, at least for, well, when you're washing your hands, it's 20 seconds. With the alcohol, using those agents, my understanding is you have to be wiping your hands and leaving it on also for about 20 or 30 seconds, but I'll defer if others have another view of that.
Yeah, so I think what I usually what we've recommended during this webinar mini series that we've been moderating on disinfectants and sanitizers has been to really follow the instructions provided for the specific chemical. They will differ from chemical to chemical, also depending on the concentration of the product. So I think what is recommended here is to properly, and I think you had a slide on that, Dr. Goldman. The proper use of the disinfectant includes, reading the instructions specific to the product you plan on using, and also making sure that you are using it for the appropriate indication and environment, including, using a sprayer, being careful with these sprayers, I think is important, and you pointed it out, because you're basically spraying these chemicals that are irritating if inhaled, as opposed to, as you said, putting them on a rag and then applying them to decrease the amount of exposure you get and other people get in the setting you are using it. So I think that's a very wise recommendation that you made about the sprayers. There's a particular hazard there because at the end of the day, you know, you may not be wearing the appropriate respiratory protection or the goggles, you know, when doing that, although you should, if you're about to spray these chemicals, to put on a respirator and goggles.
And the person brought up the diaper question, says that it's not the baby they're talking about, it's the area around the baby, like the changing table. So,
Oh,
which is perhaps a different issue.
well, in that situation, you know, you could consider moving the baby and then wiping it down with either of the agents. You know, again, we're not talking about COVID here. You're talking about normal cleaning.
Right.
So it's mostly a cleaning issue, I would think there. And, you know, you can
Soap and water, maybe.
Yeah, soap and water, or just soap and water, or again, one of these things that would be a wipe. So it's going to be less toxic if you have any skin contact with it.
I think it's essential, again, to emphasize here the importance of ventilating well these daycare settings when you're doing that. And I know it can be challenging if you're doing that multiple times a day.
Yeah.
Also, being cognizant of the hazard of spraying these chemicals if they are disinfectants that are being used, and using the appropriate protection if you are in that situation.
Now, I guess somebody just wrote here they're using hydrogen peroxide on the changing table.
Yeah.
You know, it's irritating if you're breathing it in. And again, I try to encourage people to do more wipes and not sprays, even though sprays seem to be faster and everything. So I think wiping, sure, hydrogen peroxide, but then you have to leave it there for a while.
And I think there's a question in the queue about foggers. Just want to take that opportunity to announce that we are planning, hopefully, a webinar in the next several months on foggers and sprayers. So we'll dedicate a whole webinar on that. So please stay tuned to our email communication forthcoming.
In general, I just try to advise people not to be putting irritants into the air, whether it's fogging or spraying ozone or things like that, because these are agents that are irritating. And I'm glad you're doing the webinar on fogging, because we've gotten some questions about that also.
And here's a question for Dr. Romeo. What are your sources for risk in pregnancy and lactation? Do they consider job-related use or household use, or a combination of that?
Sure. So the different studies that I've seen, just because of the population that they could get included in those different research studies, they're usually occupational. So nurses or other healthcare providers that are using some of those different occupational exposures. There may be some of those for some of the Teratogen information centers that do those research studies for household use, those clients that are in those studies, but most of the studies are going to be occupational use. The frequency may be different in the occupational use, but again, you shouldn't be getting much of a different exposure other than the frequency of it, because you're not really ingesting those. You'll smell them, have those smells a little bit more often, but again, not really having a direct exposure to most of those.
And
Yeah, I've seen. Go ahead, stop.
Sorry,
Question.
I had a follow-up question, Dr. Romeo. The teratology information centers that are available for consultation, do they receive referrals from our poison centers as well in the US?
Yes, yes, very much so. They usually have good working relationships. For example, here in Utah, ours is at the University of Utah, and we have a working relationship with them that, yes, if there is a mother that has a question about an exposure, the poison control will answer the questions about her part, and then they'll send her over to us, and we'll answer the questions about how it might affect the fetus or the breastfed baby. So that's a very good working relationship that's involved with all of those different centers across the U.S.
Thank you.
Margaret Willis asks, are any data on male reproductive health and fertility available?
So I'll take that one. For most of those different exposures that dad has, we don't see any increased risk of birth defects or other problems. So there may be, for fertility issues for dad, there may be some issues, but not in terms of birth defects and other outcomes for the baby. Now, for mothers, different fertility issues. Again, the products that we're talking about today, those cleansers, disinfectants, sterilants, she's not likely to get much of a dose of it. Of course, if we have a direct exposure, we would want to talk to the Poison Control Center and learn a little bit about how that might affect her health. As we heard earlier today, in the absence of maternal toxicity, we usually don't see problems. But if we had a toxic exposure, we'd have to evaluate that individually.
Okay. And finally, what should you do after being exposed to disinfectants in the air?
Well, what would be the nature of the exposure? I mean, most of the time, just from a quick, if you walked into a room where somebody had been spraying, most of the time, the issue is going to be one of irritation. And it could be irritating to the eyes, in which case you could wash out your eyes or your throat. Again, how much a short-term exposure, how much would you really absorb into the bloodstream? I think it's probably on a low, very, very low order for the alcohols and quaternary ammonium compounds.
And I would add to that, because there's a question about the inhalational hazard of quaternary ammonium compounds, which is up in the queue. I think it's first thing is that these quaternary ammonium compounds are typically not volatile. However, when they are sprayed, that's a different story and different route altogether. So we have to be careful with spraying these more than just applying them to a surface and worrying about the inhalational hazard. Also want to point out what Dr. Goldman had mentioned regarding the percentages, the strength of some of these chemicals. And a great example is hydrogen peroxide, which is used safely in mouth gargle solutions, etc., at low concentrations. I guess the issue will happen here when you are using the higher concentrated products. Some of these lower concentration products are acceptable as sanitizers when they are really in the low concentration. I think somebody had pointed that out in the chat as well. So thank you for placing that comment in the chat.
Right, they're not in the hand wipes for the reason that I mentioned, because to be active against, I think, COVID on a surface, it's like 3%. So that's not usually what you would be putting in your mouth. I think it's a lower percentage than that. And they're irritating to the hand. So I haven't, but maybe other people, I haven't seen hand wipes with the hydrogen peroxide. We've mostly seen the alcohol wipes and the benzalkonium ones.
I think the issue is that I've noticed at my workplace is that they are available to sanitize your, to disinfect your stethoscope.
Right.
Oh, yeah.
Mm-hmm. So you end up like, putting on gloves, cleaning. Yep. You may end up grabbing a piece without gloves just to clean up real quick. Or so.
Yes, had that very experience.
Yeah, I tend to just grab the alcohol wipe and clean my stethoscope with that. But actually, instruments are sterilized with hydrogen peroxide. A number of the scopes and other things are soaked in hydrogen peroxide. And I'll also say that during the time of the mask shortage, the masks were being sterilized in an atmosphere of hydrogen peroxide, not with any humans in there. So we know that in high enough concentrations, it's effective, but for different things. But in terms of its common use in our homes and use on hands, it would not be something that we would usually use on our hands.
And I want to just add as well that one of our participants has commented that the EPA list indicates contact time recommendations by infectious agents such as COVID. Thank you. That's very helpful as well. I'd like to open up here the opportunity for Dr. Wax to maybe ask some questions as well.
I think we've come to the top of the hour, and I'd like to thank all our panelists and our speakers today for really an excellent presentation. I think it was very, comprehensively described, despite the relative paucity of data. And as both speakers showed, there's just not a lot of data. There's not a lot of reports. The precautionary principle certainly holds true as we approach these sorts of issues when we just don't have much data. So at this point, we'll just move to the next slide. This webinar is one in a large series of webinars we've given over the last 16 months or so. They're all up on our website. Feel free to listen to any of them on demand. Next slide. And again, I'd like to thank the American Academy of Pediatrics and the PACU program for supporting this effort. Very much appreciate the collaboration with them. And we are planning 2 additional webinars in this disinfectant series. So stay tuned for announcements. We hope to carry them forward over the next several months. Again, to the panel and to the speakers, thank you very much. And everyone have a good day.
Thank you, everyone.
Thank you.